everyone, welcome. So today we're going to play detective and dive into a really fascinating medical mystery. We're unmasking one of medicine's greatest impersonators, hypocalcemia. Seriously, this thing can fool even the sharpest clinicians out there, showing up as anything from a weird seizure to what looks like a massive heart attack. Okay, let's jump right in.
Okay, so picture this. You're in the emergency department and your patient's ECG pops up. You see ST segment elevation, classic STEMI, right? A heart attack. The cath lab is probably already getting prepped. But hold on, something's off. Your patient has zero chest pain and their troponins, completely normal. The whole picture, it just doesn't add up.
So now what? You're the one on the spot. Your go-to diagnosis is kind of falling apart. What else could possibly be going on here? I mean, what can mimic a heart attack that's perfectly on paper, but have none of the classic signs in the actual patient? This is one of those moments where truly understanding the why behind the what, well, it makes all the difference.
And the answer, believe it or not, is an electrolyte disturbance. Yep, severe hypocalcemia is an absolute master of disguise. And one of its most dramatic performances is pretending to be an acute myocardial infarction. That ST elevation you're seeing, it's not from a blocked artery, it's from a critical lack of calcium in the blood.
Now, to really wrap our heads around how this happens, we have to talk about something a little weird, something we call the calcium paradox. Because honestly, the way calcium affects our nerves and muscles is completely the opposite of what you'd probably guess.
So, your intuition, your basic physiology knowledge, tells you that calcium is key for things like muscle contraction, right? For releasing neurotransmitters. So you'd think logically that low calcium would mean, well, less excitability. Kind of quiet nerves, maybe flaccid muscles. But what we actually see at the bedside is the exact opposite. Low calcium leads to a state of profound hyperexcitability. Wild, right?
And that is the calcium paradox in a nutshell. When that extracellular calcium level drops, the entire nervous system just goes haywire. This is what's behind all those classic symptoms we look for. That tingling feeling, the paresthesias, especially around the mouth and in the fingertips. It's what causes those awful, painful muscle cramps we call tetany. And in really severe cases, it can lead to life-threatening seizures.
So what's actually happening here? Okay, think of extracellular calcium like a bouncer or a gatekeeper for your nerve cells. It kind of sits on top of these voltage-gated sodium channels, keeping them stable, making sure they don't just fly open whenever they feel like it. But when calcium is low, that gatekeeper is gone. The channels become unstable, super twitchy. The threshold for firing an action potential just plummets. It makes your neurons incredibly easy to excite, and they start firing spontaneously, causing all those symptoms we just talked about.
So this isn't just a cool physiology effect. This has huge real-world implications. This clinical pearl right here is pure gold. If you have a patient who's having seizures and they're not responding to the standard anti-epileptic drugs, you absolutely have to check a calcium level. The problem might not be the brain's wiring, but the electrolyte imbalance that's making everything short-circuit. Okay, so let's take this new knowledge and bring it right back to the bedside. Now that we understand this paradox, we know exactly what to look for. The physical exam can give us some absolutely fantastic clues that point directly to the state of neuromuscular hyperexcitability.
You can actually go and look for these signs. Chvostek's sign, that's when you tap right over the facial nerve and you see the corner of the mouth and other facial muscles twitch. And Trousseau's sign is even more specific. You inflate a blood pressure cuff on the arm, leave it on for a couple of minutes, and the lack of blood flow triggers this really painful spasm of the hand and wrist. These signs are the living, breathing proof of those twitchy, unstable nerve membranes we were just talking about.
All right, now for the main event. Let's bring it all back to that absolutely terrifying ECG we started with. Now that we're armed with all this new understanding, we can finally decode what's really happening to the heart's electrical signals. This is where it all comes together. While that STEMI mimic is definitely the most dramatic way hypocalcemia can present, the true, most common ECG hallmark is actually a prolonged corrected QT interval, the QTC. This is often your first and most reliable clue on the ECG that something's up with calcium.
But what's really cool is why this happens. The QT interval gets long because low calcium literally stretches out phase 2 of the cardiac action potential. And on the ECG, that translates to a longer, flatter ST segment. Now, this is a key distinction. Other things cause a long QT, like low potassium, but that usually messes with the T wave itself. With pure hypocalcemia, it's all about that stretched out ST segment.
And for those of you who want to be on the cutting edge, check this out. There's a newly described and more specific sign called the Yasser sign
or sometimes the wavy triple. And what it is this pattern of 3 beats in a row, in the same lead. You get one elevated beat, one depressed beat, and one flat isoelectric beat. It creates this really distinct wavy look.
And here's a beautiful illustration of it. Just look at this pattern. You can see the elevated beat right here, followed by the isoelectric one, and then the depressed beat. This sequence creates that unique wavy appearance that seems to be highly specific for the kind of myocardial instability you get with severe hypocalcemia.
Pretty cool, huh?
And now the money shot. Panel A, this is the ECG from a patient with severe hypocalcemia. You can see that wavy pattern, the ST weirdness, the whole deal. Now look at panel B. This is the same patient, just moments after getting IV calcium. The change is immediate and it is dramatic. The ECG completely normalizes. This is what we love to see. It's diagnostic and therapeutic all at once, confirming everything in real time.
So we did it. We've cracked the case. We know what it looks like, we know the physiology, and we know how to spot it on the exam and the ECG. Now let's quickly cover the practical stuff. What actually causes this, and how do we fix it?
The best way to remember the causes is to put them in buckets. First up, problems with the boss. That's the parathyroid gland. Hypoparathyroidism is a classic cause. Then you have supply chain issues, things like severe vitamin D deficiency or malabsorption syndromes. Next is collateral damage from other diseases like pancreatitis or kidney failure, or even after massive blood transfusions where the citrate in the blood bags binds up all the free calcium. And never ever forget magnesium. Low mag can shut down PTH function, leading to a secondary hypocalcemia.
The treatment plan is super logical. Step 1, give calcium. If it's severe and they're symptomatic, that means IV calcium. Step 2, and this is crucial, the patient must be on a cardiac monitor. Pushing calcium too fast can cause arrhythmias. And finally, step 3, once they're stable, you have to play detective again and find the underlying why. You've got to treat that root cause to make sure this doesn't happen again.
So, let's end right here. The next time you are faced with a truly baffling case, a seizure that just won't break or an ECG that's screaming heart attack but everything else feels wrong, I want this question to pop into your head. Remember the great impersonator. Remember to check the calcium. It might just be the one clue that solves the entire mystery.